Hey, I'm Mike Infantino, and I'm here with Brendan Glacken.
How you guys doing?
And we're over in Bethesda, Maryland. We're going to go hang out with Michelle Layton and Colleen Whiteford, and we're going to see what Myopain does. Let's go.
Let's go check it out.
Here we go.
How you doing, everybody? I'm Brendan Glacken. I'm the Vice President of the AMC.
And I'm Mike Infantino. I'm a member at large.
I'd like to thank Dr. Colleen Whiteford and Dr. Michelle Layton for joining us today. I'd also like to thank Myopain Seminars for the presentation we're about to put on.
So today we're going to be talking about the role of connective tissue and muscle in anterior knee pain, and we'll get started.
Eddie has a history of a left femoral fracture and a right fibularis tear.
Correct.
And narrowing it down, he hurts everywhere.
Essentially.
Too much for a young man. So we're going to focus, though. We're going to just try to make it simple, especially with somebody who's hurting in a lot of places and not moving very well. We just opted to focus on the knee, and maybe we'll look at ankle too, since he's had the fibularis tear, and we'll see what we get. We're gonna take it from the perspective of the role that the connective tissue can be playing in restricting or allowing movement, and then how that plays into his knee pain. It's really, from this perspective, it's not about the joint, it's about what's happening at the joint because of what's not happening in connective tissue mobility. So, I might have asked, is that medial or lateral knee pain, and that would give us a clue as to where we might want to go with that. Theoretically, what we're looking at in a squat is internal and external rotation. So we're looking at the soft tissues that rule transverse plane movement in the knee. And let's just finish that. Now we're going to look at sagittal plane movement in the knee. So movements, it looks like from what we got there, transverse plane with the squat is his most restricted. So that might give us a clue that we want to look at where the connective tissues converge to allow transverse plane movement at the knee. Inversion brought on lateral ankle pain, which would kind of go along with this history of a fibularis tear. And then we had limitation in squat. So one thing's telling us frontal plane at the ankle is restricted, and then another movement test is telling us that it was transverse plane. So a little bit of a mixed bag. So now all we're going to do is use palpation to try to confirm where we might want to focus or at least begin treatment on him. And we're looking for where tissue is tender, where it feels densified, because that would be where it's probably restricting movement and then ultimately showing up as his knee pain. So what we're going to do is have you lie down. Let's just say we'll put you let's go on your stomach first, and let your feet hang off the bottom. And so we're going to go to specific points that, based on the work of the Italian research team led by the Steccos over in Italy, that they have elucidated a lot of different places where the fascia and muscle force vectors converge to allow different movements. I'm just going to go to where they are known to be by anatomical dissection on unembalmed cadavers and see where he might be really, really involved and where we might get the best idea of where to start treatment on this guy. So I'm just going to raise these up a little bit, okay? And so there's a lot of places because we're doing two limbs. I might just pick this one. Actually, I'm going to do both of them together so I get an idea.
Right.
Okay. But you can get a sense of tissue turgor and tenderness by feeling both at the same time. I get a sense that he doesn't like it when I'm over here on his right leg. And I don't know if your face can be seen on the camera, but I can sort of hear you gasp, and I can feel it a lot fuller in here. And so it is denser, it's firmer, there's turgor and there's tenderness. We're gonna pick the right leg just so this doesn't get too long and drawn out. But I'm gonna come around here because I want to check out now. I'm gonna go to a specific site for sagittal plane movement at the knee where the force vectors of fascia and muscle converge. So we're in sagittal movement in the posterior direction, which would be called retro, and it's going to be right on the medial aspect of the biceps femoris. And I've already palpated with my hand that this side feels different than this side. I want to go a little bit harder with it, and I just want to get a sense of, is this really dense and thick? And what does he have to say about it?
That doesn't feel good at all.
Yeah, because I'm looking for probably his worst spot. If I can find where this feels the most dense to me, hurts the most to him, is the most uncomfortable for me to be on it, and if it lines up with the movement restriction, then we've got a good indication that that might be the most effective place to treat him. So this one definitely gets our attention. It doesn't take much to just switch over, and I want you to bend your knee and turn it out a little bit. So that was for sagittal plane. All I have to do is move a little bit anterior. Now I'm going to be able to be on what's called the center of coordination, where the forces converge to allow transverse plane movement and external rotation at the knee. And that's, can I have you come over to me a little more? Thank you, Brandon. You can keep your leg there. And this is going to, where I am, I'm on, this is vastus lateralis, the ridge of the vastus lateralis meeting up with the biceps femoris. And theoretically, I have a nice little place I can get in here, and he's already wincing. And my goal isn't to make him wince. I just want to get a sense of tissue turgor, tissue tenderness, densification, and how this, where is the worst place. So he's confirming that external rotation, transverse plane, was about the worst for him. I think we're just going to stick with, let me have you turn over. I'm going to stick with the knee for the moment.
Colleen, could you describe what a densification is?
It's a place where the tissue is not gliding and sliding and moving. Hopefully some of this was touched on maybe in the video that might have been included with this prior, but where we have layers. You know, we all know we have layers in our subcutaneous, and where our dermis, epidermis, and all our different layers of fat and loose connective tissue are lined up in a somewhat orderly manner, but there has to be some space between them, and there has to be the ability for the layers to glide and slide and move around on each other. And our layers are oriented so that one layer may rule more in the direction of frontal plane, another layer sagittal plane, another layer transverse plane. And when they are not moving around on each other is when things start, or when they're stuck together or densified, then they're going to not allow normal movement at whatever joint it is that they kind of rule over. So those are the places I'm going to, are those densifications called centers of coordination, where movement for either transverse plane or sagittal plane movements are ruled at the knee. So now we're going to be on the, we're going to go to what we can get in this position. Here I can get on, I'm back to sagittal plane. So in here, there's a center of coordination that happens right about here in the knee for sagittal plane movement in the anterior direction. And this was kind of what I was looking at when he was lunging. And typically there's something, I can feel some, yeah. He says he's sensitive, and I can feel it's just where there should be, when I go here, it's not the same feeling. I can move this up and down, side to side. It goes freely, and this doesn't bother him. I'm right on his rectus femoris here. But when I come to where I know there is a center of coordination happening, and that's normal to have it. I mean, every region of the body has a center of coordination for tissues ruling movement, in this case at the knee. But what's different about this is that it's not moving here. Right there, it will not let go. And that was the same thing that I felt back there. So he was saying transverse plane, external rotation at the knee was the worst. And then sagittal plane in the front direction or anterior direction was the second worst. And then sagittal plane backward movement was his third worst. All right, all we have to do now, we got a couple more spots. Now we're going to just be at the other end of the plane. Now I need to palpate where the center of coordination is for internal rotation at the knee. And that's going to put us right in his VMO. And he doesn't like that either. Not at all. And I could, it's an interesting feel when you just move a little bit off. It's not the same. And it feels like it's stuck. It's tender, it's fuller in a way, and the tissue just has a very different feel to it, and it's right there. I can come down here, and I probably don't get the same response, but right there, and it,
That's the spot.
yeah. Okay, so that would be for the center of coordination for internal rotation ruling this knee. But so far we've covered sagittal plane movement at the back and the front. We've covered internal rotation and external rotation was his worst one that he said so far. And then we all only have left frontal plane movement. That's going to put us right along here on posterior to his VMO, more on like gracilis and maybe distal part of adductor magnus and all his adductors coming together here. He's not indicating that's a problem. I feel like there's nothing there compared to some of the other places. Then the only other flip side of that plane of motion would put us out here. I should have done it when I had you on your stomach. I just forgot it. I've never been on TV before, so there you go. All right, so that's going to put us right in the middle of his iliotibial band, which is a very common place for a lot of people to be sore. But I'm looking for, okay, does it line up with, is he uncomfortable there? Does it not move there? Does it feel dense, thick, stuck, turgor, tenderness? And actually, most people are very uncomfortable with this, and he's not. He's not indicating anything. And, you know, yeah, iliotibial band, it has a feel of thickness anyway because it's a specialization of the fascia where it's coming together and really being thick and a little less mobile over the vastus lateralis. But nonetheless, that's not giving him any trouble. So our worst spot was external rotation ruling the knee, and that was like biceps femoris short head, kind of between vastus lateralis and biceps femoris. So let's look at treating what we found to be probably his worst spot, which would correlate with external rotation at the right knee. And let me have you turn back over because it's just more ideal for treatment on that. Good. And I want you to put your leg kind of bent out a little bit. There you go. And I can access it now very nicely. He's nice and stable and comfortable and all that. So when I come to this anatomical site that's just kind of a divot between vastus lateralis and biceps femoris right in there, what I'm doing is I'm determining that this is his worst based on number one, it doesn't move. I cannot move these tissues. If I go up here, I've got a lot more movement in definitely every direction. This is okay. This isn't bothering him. And it's not that I'm pressing pretty hard here, but when I come down to this specific site, it feels more restricted. It just feels there's a lot more tissue turgor and tenderness associated with this area. Am I right?
You're right.
And it's restricted. And it's especially restricted in a superior to inferior direction. Caudal cranial. It just will not move that way. And so treatment, assuming he's consenting.
I can see.
And quick question. So the amount of pressure you put in, is it always the same depth that you're going, or are you addressing different layers as you work down?
That's a good question. I didn't get into that much detail with it, but I'm targeting the deep fascia. Superficial fascia, much more up on top, lighter touch that you can assess and treat. I'm going for deep fascia, the last layer that is attaching to muscle and enveloping muscle all the way down to the center of it. So the way I would treat it would just be, this isn't a, well, it is pretty uncomfortable. But hopefully what will happen is that usually I tell people for the first minute it might be about the worst. Am I right on that sore spot? Yeah. Yeah, it's pretty uncomfortable. So what I'm doing now, we're kind of doing two different things. We're trying to elicit a biomechanical response by using friction and pressure to sort of break up where the fascia and all the connective tissue layers have gotten stuck together. The mobility's gotten lost, and we're trying to restore it just by introducing friction and asking the tissue to move. The other element we're introducing is biochemical, and we're trying to stimulate actually a inflammatory process. And part of that is going to facilitate hyaluronic acid being released in the area, which is a lubricant for these layers of tissue to start sliding and gliding on each other. So this will move, but also so it will stop tugging on his knee. And sometimes this can take 2 or 3 minutes to let loose. Sometimes if it's bad enough, I'll use a laser on it. And sometimes if it won't let loose, that would be when I might needle it, which we'll talk more about later. Okay, so what I feel happening now, this is really starting to move a little bit better. He's very restricted here, but it's starting to give more. My elbow is covering more ground. You could do this with your knuckles, but I like to save my fingers. Elbow works much better. How you doing?
Doing pretty good.
So our goal with this is to try to bring this down to about 50% of what it was when we started. So a lot of the chemicals that are present in these densified areas of fascia are remarkably similar to what's been found in myofascial trigger points. pH changes in the tissue and just hypertonicity, all sorts of issues that are associated with myofascial trigger points are also found often in these areas of densification. All right, are we there?
Yeah, we're there.
Okay. I want to do the other side of that plane of motion. This is transverse plane movement. And you may say, well, you know, the knee isn't big in transverse plane movement, but it has some. And when you're missing an element of something that is supposed to be there, that can be a big problem. Okay, how is that now?
Actually feels better. So.
This was a bad one. I want to check this one. Not so bad.
Not so bad.
So sometimes when you take the tension off the soft tissues in one area or one site, center of coordination, it kind of just starts letting things up. That's still your worst, though?
Honestly, it doesn't hurt as bad anymore.
Okay, a little bit there.
A little bit.
I'm going to work this out just because I want to balance this thing out. The thought process is, with working with centers of coordination, you need to have a balance between the planes. So this is the internal rotation component for transverse plane movement at the knee. And this is already moving much better. And he's a lot less sensitive. And it feels like, too, the tissue turgor is calming down some. I could use my elbow on this. I just decided I'd do this just to show an alternate technique, but same idea. I'm asking the tissue to move in all different directions. I'm pressing hard enough so I can be on the deep fascial layer. Okay. Is it half of what we had when we started?
I'd say so, yeah. Very
Okay.
tolerable.
Now what would have been really nice was if he couldn't squat or do things and then he would get up and I'd retest and he could squat, but we didn't have a great restriction or painful knee with squatting, but let's just get you up anyway and see how it looks. And just stand in there like you were, and just, let's go into a squat. Is there any change as far as you perceive it?
Yeah, it definitely feels a lot less tighter on this right side.
And we really didn't rehearse this.
Wasn't rehearsed.
That should be
Was
very
not-
obvious.
was not rehearsed, yeah. It feels great. It feels great on the right.
Okay, is anything hurting now somewhere else?
No, I think it's typically just the
Okay.
right side. It kind of gets me.
So that's a very limited component of what you would do with the fascia evaluation and treatment. More complete would be looking at him from a broader total body perspective, but we had to bring it down to a bite-sized chunk. So, all right then.
Thank you very much. I appreciate it.